recovery. No.
Yeah, quick.
I'll pull up my trump card. No.
Moving on. Welcome to Dad Joke Medicine, episode number 7.
I am so excited to be here. Dr. Paul Dillon.
Dr. Simon Moore. In this episode, we're going to cover the most clinically relevant articles from the September 2024 CFP journal, such as
We're going to finish off by scratching the itch around eczema and treatments, steroids, and what else?
we're going to do a blazing article on heat stroke and complications, how to identify, manage that.
Getting hot in here just thinking about that article. And how are we going to finish off? This is one of our last podcasts for the year.
That's right.
What should we go back and review?
Back in time to last year's recommendations.
Yeah, 2023, Danielle O'Toole. We're going to go over some of a 3-part series. First one, we're going to go over that here. So should we dive in?
No, because we always start with the cover.
I've only done this 7 times, huh?
Okay, so
what do you
talk.
think?
This is our cover critique moment. Let's rate this cover on a scale of
I'm giving a -5. I'm sorry.
I didn't even give you the scale yet. On a scale of -2 to -4, you think it's amazing.
This is
-5 is an amazing rating.
It's like badly drawn puzzle pieces. I just think this is you and me, and we're just putting the podcast puzzle together.
Putting the puzzle together. A stock image for the journal. Yeah, it's lacking. I'd say that it leaves some empty spaces that need to be filled.
Yeah.
Why don't we dive into the clinically relevant articles here? So, flipping through to the first one, heat stroke. This is something that could absolutely show up at the CFP hospital for those of you writing the CCFP exam, but they really frame it in a case that could come to your family medicine clinic.
So what sort of a case are they going to give you? They're going to give you a case that's got lots of red flags. There's a great checklist in this article. Maybe I'll read a little bit. So your region is experiencing a heat wave. It's December, or it's late fall right now. Areas that could have a heat wave in Canada, British Columbia.
Yeah, southern British
Columbia. Everywhere else is cold. I got pictures of snow in other parts of Canada. So for those places, what do you think?
Well, they could have a case just like this where a patient comes in for what seems like a routine office visit.
But maybe they have some comorbidities. Maybe they're a little bit confused.
Yeah, and then all of a sudden you notice their temperature is up, and you check their temperature, it's 40.3.
What? So what's normal body temperature? What's that range?
98.6.
Yeah. You're Fahrenheit off. It's actually 36 to 37.
All right, 36 to 37, completely normal, and she is just blazing hot. So this patient is at risk for heat-related illness and confused. They give a medication list. Is that even relevant? We're worried about her heat.
Let's come back to that when we talk about the risk factor. So what medications could increase your risk of a heat-related illness?
Okay. And in fact, what could this increase this patient's risk of heat-related illness? And I love this rapid risk assessment checklist.
So this is a great one, because anytime we see a checklist, we're thinking about an easy SAMP question to write. So this one talks about an older adult, and they use that at 60 years of age or older.
Yeah,
they're pushing it. Either these numbers are going further down, or it's just my age is going up.
Yeah.
I'm getting closer and closer to this old age.
My kids think that I'm about 200 years old based on the looks they give me and the way they talk to me.
So you could have mental illness or cognitive impairment. That's number 2 on the checklist. Chronic disease, living alone or socially isolated. What else do they have, Simon?
Yeah, a few more risk factors. If this person is sedentary, if they're substance dependency or use, if they got increased mobility, impaired or decreased mobility, and then if they're taking medications. Once again,
here it comes. So let's go back to what you were talking about earlier. So medications, and they split this up into 2. Medications affecting the cardiovascular system, and then medications affecting the nervous system. But you mentioned chronic disease as one of those things in that risk factor list. And you're going to treat these patients with a risk factor for heat-related illness. Going to give them some medication, which will also increase their risk for heat-related illness.
You got it, yeah.
Are you a bad doctor or a bad person if you're doing this?
Yeah, exactly. So the folks who are being treated for heat-related illness and have risk factors for heat-related illness are probably going to be on medications like these. So beta blockers, calcium channel blockers, We mentioned another risk factor is that they're got mental illness, cognitive impairment, and those folks are going to be on what kinds of medicines?
Well, you're thinking about your antipsychotics, potentially lithium, anti-Parkinson agents. So a lot of these medications, you think of elderly patients living alone, polypharmacy, at risk. So what can we actually give these patients? What advice? And then I go to box 2 for this one.
You got it, yeah. So as a family doctor, I would say send them to Emerge. And now they're your problem as a ER doctor.
No. So where else can we send these patients? And this is where this topic gets really interesting. I don't know if they snuck this in on purpose, but they want you to send them to cool places.
So that's the way to prevent
Heat-related illness.
Send
Send them to cool places. So I was like, I'd probably go to the bar, have a nice cold drink, but that's not on there. That is not a cool place.
I think that my kids would say that the coolest place is any room that I'm in.
I've talked to your children, and they say the exact opposite, actually.
Okay, fine. Okay. So what kind of things would we recommend? You know, it talks actually about advocating in our community so that our community can have places with a maximum internal temperature, community centers, family or friends with air conditioning. That's all in here. What else could we suggest to reduce their heat-related illness risk?
Cool public places, churches.
Mm-hmm.
So I don't know if there's been like a randomized control study of the temperature in churches. I don't know if do mosques have higher temperatures or mandirs or Sikh temples? I'm not sure why they specifically say churches. Maybe it's because they're made of stone.
Okay.
That could be it.
That could be
Maybe,
it, yeah.
Maybe I'm the one that doesn't know.
Yeah, I mean, I remember I was always told to go to church to avoid the heat. So there you go. Reducing risk of heat-related illness.
What sort of hot places would you go to from church?
From church?
Actually, I'd say if you avoided church.
This is not a religion episode. But I'm happy to share with you about that if you want to stay later after a recording.
Later. Okay.
Let me tell you about my friend. Not interested.
What?
Interesting.
No, tell me. What friend?
What friend? My friend with a cool home that I can go visit to reduce my risk of heat-related illness.
Oh, interesting. What's his name?
His name is light-colored clothing when outdoors or in the sun.
Okay, so I think we've burnt that topic to bits.
Yeah, okay.
Are we done?
I think we have exhausted that one.
Exhausted.
And,
It's gone up in smoke, really, I'd say at this point.
You were just firing on all cylinders with this one. Indeed. Love it.
I'm exhausted.
Exhausted?
Firing on all those cylinders. Exhaust.
Exhaust, because that's a hot
No,
item.
because that's what happens with combustion.
Combustion
In a car.
Engines.
Oh,
I wouldn't know. I would own an electric car.
Oh.
I don't yet. I can't afford one. I'm a family doctor.
That's for specialists.
Yeah, exactly.
Okay. Let's go. Rapid recommendations.
Done. Next article.
It was so fast I didn't even see. So, updates from guidelines 2023. This is part 1. Danielle O'Toole's got 3, so we don't know what's going to be in the final one. This one, I think she's stuck with like cardiovascular. That's the big stuff I took away from this. So, cardiovascular, diabetic, 2 pages, everything from 2023. What's your biggest takeaway here?
Oh my gosh. It would have to be the single most effective drug when it comes to not only cardiology and endocrinology, but also nephrology.
Water.
SGLT2 inhibitors. No, that's their arch nemesis.
Arch nemesis.
Yeah. We'll get to that with the wet phenotype of cardiovascular disease. But here it says specifically, you've got your patients with heart failure with preserved ejection fraction. We used to call this diastolic dysfunction. Now we call it preserved ejection fraction. And for so long, we're like, what do we even give them? There's no great treatments to help them. And now, bam, SGLT2 inhibitors.
So the key thing here is just to remember that heart failure with preserved ejection fraction. And then let's take that and go into heart failure phenotypes. And I'll tell you an honest story. Mm-hmm. So just 2 days ago, I had a patient and I thought he had like a touch of heart failure. He was waking up at like 2-3 in the morning, really short of breath, would go for a walk, pretty like a med student history at 3 a.m. in the ER. And I came back to him. I said, you know what? I think you got like a little bit of like heart failure. And that's a heavy word. So I told him, and he was like totally down. He was cool.
Kids these days are not used to hearing the word failure.
Yeah.
I got to tell you. Like heart delayed success.
Heart delayed success. But this guy was not a millennial. So
heart
I go back.
Trying as good as it possibly can. Heart, everybody passes. That's what you've been diagnosed with.
Heart participation.
Heart participation
Your heart
ribbon.
is participating in your
Not
failure.
a good thing.
So I go back and I start typing up my note, and all of a sudden I literally hear like weeping. Yeah, his wife, she was sitting there at the bedside, heard me say heart failure. And at that moment, she thought like her life was over. So it's just the value and importance of words. Then I had to go back and tell him after his echo, his ejection fraction is 65%. And she's like, oh my God, no. What happened to the other 35%?
Like, no, it's amazing. That's a normal ejection fraction.
Yeah.
Which is why you have heart failure with preserved ejection fraction. Yeah. So what about the folks with reduced ejection fraction below 55%?
So then I think they say, what is it here?
Your angiotensin receptor neprilysin inhibitors.
Neprilysin. So that's new.
And then the
have you seen this yet?
Yeah, I had a patient today.
Okay. Oh, did you? Okay. I haven't seen it. Hasn't reached the Sunshine Coast yet.
Oh, right.
A little rural. That's your urban medicine.
This patient was so close to the tertiary center. They worked in the tertiary center, and they are taking the advanced drugs, and then they would also be on a mineralocorticoid receptor antagonist to enhance their diastolic dysfunction.
So you mentioned the different phenotypes. So this is a new de novo way of talking about our heart failure patients. Is it?
Good one.
Huh?
How did
is that
you
good?
de novo that?
Oh.
So it actually makes sense because when you have a patient with decompensated heart failure, they're going to fall into one of 5 camps, really. You can put them in these boxes. And what is the evidence for this?
Oh, this I'll have to check. Did they actually
No
say?
level of evidence provided. Well, this is like...
That's perfect.
But we've
That's
seen
fine.
this clinically. The cardiologists see this all the time. And I think we can all guess what is your first most common heart failure presentation.
Wet.
You got it.
Yeah. That was my patient. Bit of furosemide, Lasix, gone.
Yeah. I had a patient
Sorted.
today who was so fluid overloaded that not only did they have the edema, but they actually had a blister on their leg that was filling with edema, like at the bedside where you could see it filling. With
What?
Clear fluid. Their edema had ruptured. In fact, palliative patients sometimes can have it weeping out of their skin.
How long were you just sitting there watching this without doing any treatment?
Popcorn was made. We pulled up stools.
Watch and wait treatment.
Exactly.
Yeah.
So wet, easy diuretics.
Okay. Second one, de novo, so new heart failure, as I mentioned. And then moving on for that, worsening. So someone who's chronic and they're getting worse.
They talk specifically about how to manage each one of these phenotypes, and we can bundle those together. Just use the guideline-based management and give them multiple medications to manage their heart failure.
Just keep going, especially for the frail and cardiorenal patients. Those are tricky. I'm often getting my specialist colleagues involved in those ones.
Yeah, and really they say, titrate carefully. You're going to be reducing the amount of drug increases you're making, adjusting and tweaking and titrating very, very carefully because you could upset the apple cart very easily.
The apple cart?
Mm-hmm.
I go to the supermarket. What an apple cart is upset? Yeah,
you've never heard of upsetting the apple cart?
No.
It's a manner of speaking when the apple cart gets angry.
Oh, okay.
Yeah.
It's some core truths there.
Mm-hmm. Yeah. I'm going to have to look for a sauce on that one.
Don't be saucy and tell me about one of these. So we just talked about medications we're going to give to patients. What about taking medication away? When would you do that in patients who have had an MI? Say it's one of your patients. You've horribly managed their heart failure. So most of your patients... Hypothetically, right? You have to say hypothetically, don't you now? Isn't that what the college told you, to always say hypothetically?
Yes.
So, patient with MI, you start them on the... Whoa! I got so excited there. You started them on a cocktail of medication.
I specifically remember, early med school, seeing this internist say to the patient, you've had a heart attack, you're going to be going home on 3 different medications.
And what were they?
We're talking about the statin,
Yep.
we're talking about the aspirin.
Yeah.
And we used to tell people beta blocker
Beta
for life.
blocker. Yeah.
For life. You're going to be on this drug for the rest of your life. Wrong.
So
It's changed
now, at 1 year with preserved left ventricular function, consider taking these patients off.
What? We're going to stop a beta blocker in somebody who's had a heart attack?
So I've seen this a lot in my elderly patients, and they've just put on a beta blocker, set it, forget it, Ronco food dehydrator, easy family medicine, don't do it. But now, take them off at 1 year.
And again, it's one of these things that makes sense because we see these patients down the road, and how do they look?
Tired, depressed, and fatigued.
They look like a family medicine resident. They're so exhausted. Stop that beta blocker.
But they're tired because they're in their 3rd year of residency.
Yeah, exactly. 3rd year of beta blocker. So we need to be careful, though. We don't just stop at carte blanche. We stop it specifically for folks, like you mentioned, preserved ejection fraction. And then the ones who aren't having heart failure, they aren't having arrhythmias, and the ones who aren't having uncontrolled hypertension.
I've seen a few cases of this. After an MI, patients just get down, depressed, or they start on a beta blocker. I think it's undernoted the depression and fatigue some patients feel on beta blockers. I've definitely had a few patients, I've stopped their beta blocker, they're active, they have an MI, and then all of a sudden they're just exhausted.
Wow.
Stop the beta blocker, they get better. So I wonder how many patients are going to get better with this recommendation.
Well, that is an amazing 2023 recommendation. There's a couple other ones. I think the most clinically relevant ones here are going to be, I love this one about if you've got a patient on insulin with type 2 diabetes, are they taking this medication as well?
Yeah, and so this is interesting. So start them on insulin, weight goes up, and they talk about adding a GLP-1 RA. So liraglutide would be one example, and that brings their weight down,
You got
which
it.
improves hemoglobin A1C.
Yeah, in fact, multiple trials have demonstrated that if we combine these two, so think about it, insulin plus GLP-1 RAs, and then you're going to get better body weight, you're going to get better hemoglobin A1C reduction than just using insulin alone.
And it's 2023. This was the 2020 Diabetes Canada guidelines. So this aligns with that. So another potential game changer, another benefit to your patients. Get that hemoglobin A1C down.
You know what the real game changer is,
What?
though? Is that this was the 2020 Canadian Diabetes Association guideline recommendation,
Yeah.
and in 2023, the American guidelines finally caught up to the Canadian guidelines.
And then now we're printing them again.
Not the other way around. Usually it's the Canadians are following the Americans. So I'm
Is it? Is that true?
when it comes to medical recommendations.
Oh, okay. Sure.
So you want to go into politics
Good
there?
recovery. No. I'll pull up my Trump card. No.
Moving on. Okay. So actually, I just heard a quote from somebody who said, he posted on his Twitter, I can't believe people want to vote for that old white guy. This is back when it was the two old white guys running. He's like, you wouldn't believe the amount of hate I got when I was just making a joke because they were both. He was like, I thought it was like totally nonpartisan.
And
But
it
no,
wasn't.
it
I think
is that
everything is
polarizing.
partisan.
Look at you can see if you look at the number of likes on our video right now, you can see them going down because we brought up politics. Speaking of which, like, subscribe, and send us an email. Tell
Like,
us
subscribe, share with your family members.
and stop their beta blockers if they're over a year after their MI.
There. Boom. Love it. Solid. Okay, let's keep going. Last one. The top article. Tools of practice.
I love this article. The top article on this topic.
Ooh, this is topical.
Yes,
It's
that's
visible?
the first word of
Yeah,
the
I
headline. It's topical
Topical
corticosteroids.
corticosteroids for atopic. Ooh, another top in there.
Oh my goodness.
Woo. Did they do that on purpose? Atopic dermatitis.
It's like a rap. Like these guideline authors are.
Oh, it's
rapping.
Michael Allen as well. What else does he do?
He's the CFPC CEO.
And he's publishing in the journal?
Not anymore. He's focusing on rescuing the CFPC. So why did we get canceled from the FMF?
Why don't they invite us on the CFP the CFP podcast?
Yeah, I don't see your
They have
picture
one.
there.
Never got an invite.
No.
Staying human during residency training.
Oh, well. So let's talk about the risks and benefits
Okay.
of using topical corticosteroids for atopic dermatitis in children and adults.
So this article, what are my takeaways from this one? I really like the prevention piece of still using steroids 2 days out of the week to avoid flares.
Sorry, because we usually use, I've got to clarify this.
Yeah.
You've got a flare of eczema. It's really itchy. Use your steroid. Use it for a few weeks and then stop. Isn't that the usual?
But then, sure, you stopped, say, after like 6 weeks, but then use it twice a day. So weekend therapy is the way I would call it. So 2 days out of the week, use it to prevent future flares.
All right. And is there evidence for that? Well, actually, this whole article is about the evidence. So it talks specifically about that's going to help out 60% of patients avoid a flare. Compared to placebo, only 30% would avoid a flare. That's an impressive.
That's solid. And it's once again, it's patient-centered. Patients are going to remember maybe once, twice a week. That's going to be easier to do than every day. I know patient, you forget, you're busy, but you know what? Once or twice a week, totally doable.
You know, I've got my doubts, though, because I wonder if the evidence might be a little bit thin when it comes to does that cause the skin to become thin?
Thin. So, do we have a lot of evidence on that? And I think the answer is no. I mean, I mention it to my patients.
Kidding?
'cause I was
35
taught-
RCTs? That's
Yeah.
not enough evidence for you?
Yeah, but what's the N value? Yeah,
3,576.
3,500.
So less than 1% of people will report skin thinning.
Skin thinning.
Or thin skinning, I say, when
Thin.
I'm having dysarthria.
Okay. Oh, you're skating on thin ice right now, my friend. Tacrolimus, 0.1%.
Yeah, let's talk about the calcineurin inhibitors.
Inhibitors, because it's not just tacrolimus. There's a second one. Is there not in Canada?
Pimecromylus. I know you know how. I know you know what it's called. You just don't have to pronounce it. So, potency of that, is that going to be like a strong steroid? Is that going to be like a weak steroid?
I don't know how potent pimecromylus is.
Wow.
Oh, yeah.
Peter Piper picked a peck of pimecromylus. Potency. Wow. That's like the tongue twister you were using to try and warm up for our podcast presentation. So well done. So they would actually rate it as a mid-potency equivalency.
Okay. Sounds good. That's a great point.
Moving on.
Moving on.
Clinical.
That's pretty mid.
Great for, eczema flares in the face. You don't want to be using your potent
interesting.
steroids
Okay.
because skin thinning can occur in 1% of folks. And turns out short-term adverse event is less than 6 weeks. So steroids are safe to use up to 6 weeks. Long-term harms? Not
Don't
known.
know. Don't know. Too new.
And that is September 2024. CFP Journal. That is it for Dad Joke Medicine, episode 7.
I had a great time here with you. Hope you had a great time listening wherever you are.
See you next month.